The TMJ-TMD conundrum is real and has been puzzling the dental and medical professions for decades. This is the TMJ-TMD Demystified podcast with Dr. Tony Urbanic, where we'll connect the dots between TMD symptoms and the actual cause. We'll tackle common TMD misconceptions and educate you, the practitioner, about a simple, tested, and proven TMD solution that has already provided relief to thousands of patients, while helping practitioners build an additional source of income free from insurance control. Welcome to this episode of the TMJ-TMD Demystified podcast.
Good morning, TMD Warriors. We're here for the next episode of TMD Demystified, and I am Tony Urbanic. Today's topic, today's episode is entitled Alice in Wonderland and TMD TMJ. And please let me explain. I've been planning this episode for several weeks now. I knew it was coming. And it really is going to be a summary of what has happened in my space on this problem in the past 13 years. Not to leave you in suspense, but when I entered an independent investigation of TMD, quote, TMJ, roughly 13 years ago, I did not know that I was going down a rabbit hole. And as I went down the rabbit hole, it got weirder and weirder and weirder and weirder, just like Alice in Wonderland. And as I thought about this over the past several months and leading to this episode, I just have to talk about it in this manner. Anyone who has honestly emphasized the word honestly and ethically emphasized the word ethically, interested in this problem, whether or not you're interested in solving it or not, or participating or not, is not necessarily the issue. But anyone who is honestly and ethically wanting to look at the problem, you must be aware, you have to be aware, you need to be aware of what I discovered over the past 13 years about this problem. And it isn't pretty, and it isn't nice, and it is very disappointing in many ways. In some ways, very stimulating because of the problem itself, now that we actually have honestly a solution for it. For those of you who are in mysticism, you'll need to go back to several of the previous episodes and talking about what I discovered, the device, and we're not going to go over that again. It really is discovered the mechanism. What I discovered was in the literature, and that is there is a autonomic nervous system mechanism associated with the endocrine system and the nervous system that stimulates muscles to get tight when a joint is damaged and inflamed, whether it works on the hip or the knee or the elbow or the temporomandibular joint. Knowing that particular piece of pathophysiology with a little cell biology thrown in there, and neuropathology, and a little gross anatomy, it explains temporomandibular joint problems, upon which there is a simple solution, which is what you do with any other joint that is inflamed. You rest it. You rest the joint. And if you rest it adequately, consistently, the inflammation goes away and the symptoms go away. But that is the basic of the discovery, quote, discovery. How can you say I discovered anything when it was in the literature? Orthopedic surgeons knew all about it. Dentists didn't know anything about it. They still don't. It's like, beating your head against the wall, getting someone to take a look at the facts. But Alice in Wonderland, if you're all familiar with Lewis Carroll and his very famous mid 18th century book, basically for children, but it was really a lot deeper than that. He wrote about all the strange characters, and strange characteristics of mid-18th century England. And I would recommend anyone who would like to spend an hour or so reading Alice in Wonderland. It is a wonderful wonderful review of human nature, let's just say. So what I discovered when I went down this rabbit hole was many, many, many things, which the deeper I got, the more I was surprised. First of all, how frequent this problem is. As an oral and maxillofacial surgeon, beginning back in the mid-70s, when my specialty as an oral surgeon tried to address this problem, which was not well known at the time, called TMJ. There were people out there who complained of all these strange symptoms. And I was on the cutting edge here at Vanderbilt, Nashville, Tennessee, and David Hall, who is an icon in the attempted investigation and research on how to use surgical principles to treat a bad joint. And I don't have time to go into that. I do have a previous episode that talks about how he used surgical principles to decrease inflammation in the joint. But overall, it was not successful overall. And between the early 70s and the late 80s, there was a process upon which oral and maxillofacial surgeons got involved and more frequent. And in our textbooks and in our congresses and in our meetings, it was promoted as something that we could contribute to solve the problem. It got very, very common, very well studied in many ways up until the late 80s. And then we had a catastrophe of Proplast Teflon implant, which I participated in, unfortunately so. I could put a whole episode, 2 episodes, 3 episodes about Proplast Teflon. And then it became obvious that surgery was not going to be the solution. And when we had just about every newly trained oral and maxillofacial surgeon doing temporomandibular joint surgery of one kind or another, various kinds, it began to taper off very quickly, where now you can hardly find a newly trained or an old trained oral and maxillofacial surgeon who wants anything to do with temporomandibular joint surgery. There are a few exceptions. Again, I could speak on that at great length, but that's not the point of this episode, Alice in Wonderland. It peaked and then fell off rapidly. Well, why is that? Because my colleagues in oral and maxillofacial surgeon, I have great respect for each and every one of them, because I knew what they had to go through to become an oral and maxillofacial surgeon. And they're pretty honest guys, and they just want to get the job done. They look at things very pragmatically. Does it work or does it not work? And they found out over a period of about 10 or 15 years where all the promotion said, do this, do that, and you'll come up with wonderful experiences and success rates. And they found that was not true, so they cut it out. And I was on that march up and down, and 13 years ago. But instead of just stopping and saying, this is not successful and I'm not going to do it anymore, I took the one additional step and said, I'm going to see if I could figure out what's going on. And because of my research background and academic training, I figured it out. But I didn't figure it out. I read the literature. I had some knowledge based on experience and training in my orthopedic residency, and a little common knowledge. And most importantly, my patients led me to the key to look at unloading the joint by saying, if I put my tongue between my front teeth, it feels better. Or what are you doing when you do that? You're unloading the joint one way or another. Now, when I first heard that and I made the first device, I had no idea exactly what was going to happen, or even how it was going to work. I did know that we had a significant number of patients with the problem who claimed if you put something between their front teeth and gently bite and bit down, it helped. It felt better. a lot. Therefore, that's called inductive reasoning. Here's what works, and then inductively you have to do the research. How does it work? Which is exactly what happened. After 20 or 30 cases, I had no idea really how it worked, at which point I went back and did some inductive reasoning and reasoned out, and then read the literature and actually remembered about what the orthopedic surgeons call joint splinting as it applies to tennis elbow, and figured out tennis elbow and TMD are the same disease. And then a little more investigation, finding out, looking at the Gray's Anatomy and looking, literally observing the petrotympanic fissure, which is a access from the temporomandibular joint into the middle ear, which will allow inflammation into the middle ear, creating tinnitus, subjective hearing loss, and vertigo. Not really rocket science. In fact, nowhere near rocket science. My edition of Gray's Anatomy was a 1953 edition of Gray's Anatomy given to me by the chairman of the Department of Anatomy at Indiana University. So when I began on this rabbit hole, first of all, I couldn't believe some of the things that I encountered. And I just want to go over these with you, ladies and gentlemen, who are following this in an attempt to be honest and ethical about the treatment of this problem, in an attempt, hopefully an attempt to stimulate you. My purpose is to educate and stimulate you to get involved. It's simple. It is not complicated. Do the necessary steps to learn how a simple device that used correctly, emphasized, device and protocol. You have to be able to keep the device in your mouth 24/7. You got to be able to speak with it. Has certain characteristics, but separates the back teeth 24/7 for 2 months, and then nighttime only the rest of your life will allow the inflammation to go down. But now that I'm 13 years into this, number one, the frequency. I used to think that, well, it's a, TMD, we had a lot of patients, surgical patients, but if I was doing one, well, usually 2, maybe 3 surgical procedures on the temporomandibular joint per week. I mean, at a certain point, I was doing 8 to 10, 12 surgeries on the temporomandibular joint per month. It's a lot of surgery, hospital surgery for an oral maxillofacial surgeon. And then that was on top of all my orthognathic surgery and cleft palate surgery and reconstructive surgery and trauma surgery, microneurosurgery. So it did play a particular part, but I spent most of my first half of my career in operating rooms, not in my office. But the frequency of this problem stunned me once I got down the rabbit hole. And that is, if you read the various studies, the studies from all over the world, different countries, they claim 15%, 20% of females have temporomandibular joint symptoms. Well, it's much more than that when you include all of the symptoms, because all the symptoms that are misdiagnosed, overlooked, the entire, subjective hearing loss, tinnitus, and vertigo are pretty much overlooked. The symptom of arm, hand, finger tingling, and numbness has not been placed even on the general list of symptoms, although it is a definite symptom. And I talk about how that occurs and why that is. And we found out because the patients would come in and say, my headaches and neck pains are gone, but so is my arm, hand, finger tingling, and numbness. Had to figure that one out. But if you include all the symptoms, it is 45% of females and a smaller percent of males have this problem. That is huge. The next thing is the misdiagnosis of the problem, primarily by the medical professionals. Again, this is a summary. This is a summary of several of the recent episodes and distant episodes that I've placed. But, my medical colleagues, constantly, when I say colleagues, I mean the whole gamut of MDs, nurse practitioners, physician's assistants that actually see patients with these symptoms. You have 45% of the female population has these symptoms. Some of them just ignore it, grin and bear it, and others seek help. And if they're having a headache or a neck pain, they're not going to go to their dentist. If they have arm, hand, finger tingling and numbness and can't figure out, they're not going to go to their dentist. If they have an ear pain, they're not going to go to their dentist. They're going to go to their ENT doctor. They're going to go to a walk-in clinic, a convenient care clinic. They're going to go to their PCP to see what's going on. And the problem is, the medical colleagues, if you get a headache, well, let's say you have a severe headache and you go to the emergency department. I mean, severe headache. Well, they may or may not get a $2,000 or $3,000 MRI CT scan. Depending on the history, they might right off the bat. But I can tell you that if you present to a medical practitioner, let's just say a family practitioner, MD family practitioner, with bad headaches and a history of bad headaches, the first thing they will do is order a CT scan, probably more like an MRI. They'll order an MRI. How do I know that? Because about 3-4 years ago, I did a presentation. I lectured to a room full of 35 family practitioners at one of the largest family practices here in Nashville, at Meharry Medical School. And I asked that question. I presented the scenario to them. Here's a scenario. You have a patient come in, gives you a history of multi-month or multi-year history of recurrent severe headaches that last anywhere from 2 hours to 2 weeks. What do you think of? What do you do? First thing you do is you think of, we have to make sure it's not a brain tumor, and you get an MRI. And then the second question I ask is, what is the most likely thing that's going to happen when you get the MRI? And the answer, I mean, everybody agreed. Everyone in the room, 35 hands shut up, MRI. And then the second question was, well, what do you find out when you get the MRI? And the consensus, the total agreement was the MRIs always come back as normal. Now, if you have 45% of females have this problem, and the diagnosis is a combination of gathering symptoms and pressing on the joint and seeing whether it's hot, meaning painful. A hot joint, when you press on it, is painful. How easy is that to do in comparison to sending a patient out for MRI, waiting for the results to find out that the MRI is normal and they don't have a brain tumor versus this? On the other hand, if you do this and you find out the joint's hot, then you know you have the TMD diagnosis and you can skip the MRI. On the other hand, if the TMD is not hot and you don't believe the problem is TMD, then you can get your MRI. The number of patients that are misdiagnosed, mistreated, misdirected, just in this one example of headaches. And then these are well-schooled, documented, trained family practitioners. And, same as a PCP, they're going to do the exact same thing. ENTs, same thing when it comes to Meniere's disease. They'll do a multi-$1,000 workup if you come in with headache, with ringing in the ears, tinnitus, subjective hearing loss, and vertigo. And everything comes back as normal. You don't have really any hearing loss. The MRI comes back as normal. You have Meniere's disease is what the answer will be, but there's no solution to Meniere's disease. On the other hand, if the ENT doctor or his nurse practitioner would do this and it hurts, then they would say, well, maybe that's TMD, and then send the patient out to an appropriate treatment for TMD. This is huge. Then here in Middle Tennessee, where all this started, because of our educational process in educating the ENT doctors, the PCPs, the walk-in clinics, and we have reached just a small percentage. I think I got the numbers at one point of the number of physicians, nurse practitioners, physician assistants working in Middle Tennessee, which is the middle third of the state. So a lot of doctors, a lot of nurse practitioners, and we have reached probably only about 3 to 5% of them. But yet we have 860 some referral sources who send us patients now because we've educated the doctors, the medical types on this problem. But the rabbit hole, is just amazing. And then, the misunderstandings and the big lie, which I talked about just on the last episode, is that this joint is complicated, which is continuously to this moment taught in dental schools, that this joint, temporomandibular joint, is a complicated joint. There's nothing like it in the body. That's not true. That is a lie. No, it's a joint like any other joint in the body, rather than there's nothing like it. It has a name like nothing other joint in the body, gigliomo-arthrodial joint. Now that is like not any other joint in the body, gigliomo-arthrodial joint. And that's the only thing that it's not like any other thing in the body. Everything else about the temporomandibular joint is similar to your hip and your elbow and your knee as to how it works, and the pathophysiology and the histology and the neuroanatomy, how it interfaces with the central nervous system. And then the deeper I got into it and I saw what my colleagues were doing, and that was really where the disappointment was. I mean, I felt comfortable. I didn't feel happy because I went through a series of surgical events, and I still have patients who had good results from surgery, but 30 to 40% of them were back in 6 months or a year, and that is a fact. That's why I quit doing surgery. On the other hand, as I got down the rabbit hole, I began to observe and look at the problem in a different way, because I had literally hundreds and thousands of people flooding into my office for care, and I heard the stories from them about what has happened to them previously. And, many of them went to what I call, appropriately so, the gurus, who use odd, weird things that they throw at the wall to see what sticks, which really has no basis in science, and certainly is not effective. And patients, the number of patients that are angry about all this is significant. Again, you went down the rabbit hole and met all these characters, just like just Alice, the Queen of Hearts, off with their heads. I mean, that's a good example. I mean, it is not unusual. Fortunately, it doesn't happen every third patient, but every week or so, maybe a little more often, I get somebody in here who I really wonder why they're coming in to see me, because they have, first of all, lost all hope, but they're just angry patients, and they want to talk about how they don't call it abuse. They're just angry. They just, because they know they've done this, they've done that. They come in with a little paper bag with 3 or 5 or 8 night guards, each, given by a different dentist. Some of them multiple night guards by the same dentist. But they're very angry people, and it's hard to calm them down. But they do, if you get in communication with them and start telling them the facts about this problem and explaining their symptoms to them so that they can understand it. It truly, their anger diminishes when they realize they're talking to someone who really understands their symptoms, understands the problem, and can understand and explain to them in their own language, in their own level, the pathophysiology of what's going on about all these strange symptoms. But following the white rabbit down this hole is exactly what I did, and I've just been amazed. So the number of needy patients with this problem is huge. The number of patients who come in and say, you're my last hope. And then, of course, the payoff is when you get their symptoms to diminish, and they come in with smiles on their face, or they come in and thank you profusely, things like that. We've talked about that significantly. It is a pandemic confusion of TMD with migraine headaches, the number of pharmaceuticals that are used when inappropriately, totally inappropriately, when the problem isn't migraine headaches, which does not actually have a definition to, other than migraine means half of the head. And but everyone calls it a migraine. Bad headache. TMJ headaches are bad headaches. And they're frequent and they're recurrent and they're hard to understand if you don't know the pathophysiology. But the number of people that have been placed on long-term migraine headache medications of various kinds with significant side effects, and the types, the categories of medications is spread all over the board because the physicians, the medical community, the medical establishment has really over the past 50, 70 years just thrown whatever they think would stick at the wall regarding this problem. But they full well admit that they don't know what causes migraine headaches, full well admit. Yet they throw things at the wall to see what sticks. And a huge part, we just don't know what part, how huge a part is temporomandibular joint to chronic frequent headaches. That study's going to be done here in the near future, one way or another. We can do that. That's not a hard study, not a complicated study to perform. It does take some resources, take some time and take some resources to put it together, but it's not a complicated study to see actually how many people with the diagnosis of migraine headaches actually have TMD headaches, because we know I see every day, patients who have been diagnosed with migraine headaches, and their headaches go away when you make the inflammation in the joints go away. It has been a trip going down this rabbit hole and seeing what I've seen. I did not expect any of this. I did not expect my medical colleagues to be misdiagnosing migraine headaches constantly, or ear infections out of the, anybody who goes into a walk-in clinic and a convenient care clinic with ear pain, which is the third most common symptom of TMD, the nurse practitioners, physicians' assistants, TMD is not even on their radar screen unless I've lectured to them. At which point in Middle Tennessee, we have many convenient care clinics who are now on the lookout for it and send patients in because now they can distinguish between TMD and other types of ear pain. But it's a real problem in the convenient care clinics, because how do I know this? Because we have just constant stream of patients who have been to one clinic, second clinic, same clinic twice, and they all end up with a prescription for antibiotics. And usually the process is they end up finally referred to an ENT, and either the ENT doctor or his nurse practitioner who know how to look at a tympanic membrane and determine whether or not it is inflamed or whether or not it is bulged, which would be an indicator of an ear infection. And they say, no, you don't have an ear infection. This must be TMD. And we have an increasing number of ENT doctors, practices, who can do that now in Middle Tennessee and send us patients, and they are included in that 861 referral sources. We have to end the misuse, misabuse, misdiagnosis, mistreatment for this problem. It's just historically, it's been going on for 70 years. So it's not, I do understand how it all occurred because there was no understanding about the pathophysiology. And it continues to be so. Half the dentist, half of you will make a night guard, and either whether you believe it or not believe it, you've been told you use a night guard and give that to the patient for their TMD symptoms. Well, if you give it to them for covering the surface of the teeth so they don't crack their crowns or they don't damage the surface of the teeth, that's a good reason to use a night guard. But if you give it to them for TMD, you're wasting your time. And patients eventually find out about this and they know it. And that's why some of them get very angry about it. And and why there are so many people who have had this problem and have these symptoms continuously for 30, 40, 50 years. I saw my day in the wheelhouse is on Monday. And just off the top of my head, I saw a patient who had headaches since she was 10 or 12 years old, and that was 40 years ago. And she had been told she had migraine headaches. And she was now a couple months down the road after using the urbanic device and protocol, and her headaches had not occurred since she started the device and protocol. And she had had this series of headaches for 40 years, since age 12. This is what we see all the time. This has got to stop, please. I mean, it's going to take a major movement to change the direction of this super tanker, large, inappropriate body of knowledge, and put in something that actually makes sense. It is going to take a little time. I understand that. If you'd like to participate in the solution to this problem, I'd suggest you start on our website, www.urbanictmj.com. You can read all about it. You can read about me. You can read about all the success stories. You can learn everything that you need to learn between that and the podcast episodes on Dental Town. It's all there for viewing, and it's very easy to understand. If you'd like to actually be a network provider, you have to take a course, either an online course, or we have a seminar coming up July 26th here in Nashville, Tennessee. Either way, that will give you the information, the license to take the license, so you're licensed to use the patented device and apply the protocol and get the results for your patients, an advantage for your patients, an advantage for your practice, because it's very successful remuneratively for you and your practice. If you'd like to communicate with me, I can be reached at Tony Urbanic at Tony@tmjservices.net. Tony@tmjservices.net. I would like to communicate with you. If you'd like to criticize, I'm happy to listen to your criticisms also and discuss it with you for sure. No problem. That being said, I look forward to the next time that I'll be able to sit down on a Tuesday morning, which will be next Tuesday morning. I have a big day planned for myself, and I had to get this episode done early and out because of my responsibilities later in the day. I look forward to next time we can speak. That'll be next Tuesday morning. Until then, I'm Tony Urbanic, and this is TMD Demystified.